Good morning and welcome to the Worcester Business Journal's last Coping with COVID-19 webcast session for 2020. It's been a long haul since March. We've produced over 13 timely and informative webcasts that we hope you've all enjoyed. Today is no different. Though likely enough, this is the first one with the snow that we can say it's better off that we're all meeting remotely instead of in person, remote pandemic or not. And it's very fitting that we're actually meeting remotely to talk about how we're all meeting remotely. I'm Grant Welker. I'm the news editor of the WBJ. I'm joined this morning by a panel of experts who will explore the role of telehealth during the pandemic and discuss its astounding level of adoption and what technologies like it hold for the future of healthcare delivery. This special session is brought to you by the support of our COVID-19 crisis series sponsors, Fallon Health and Webster 5. They've been along the ride for the entire series, and we thank them for their commitment to the community and to programs like these. Before we jump into the discussion, just a couple of notes for the audience. If you have a question, please type it into the Q&A box, and we'll get to as many of those as we can. Today's webcast is also being recorded, and a link to the recording will be sent to all of you after the event. And now onto the panel we have joining us today, Dr. Lawrence Garber, an internist and the Medical Director of Informatics at Reliant Medical Group. Dr. Carolyn Langer, she's the Senior Vice President and Chief Medical Officer for Fallon Health. Tamara Lundy, the President and CEO at Community HealthLink of UMass Memorial Healthcare. And Dr. Samya Viswanathan, who is the Chief Medical Officer at St. Vincent Hospital. And we'll get right into the panel discussion since we have a lot of ground to cover. Dr. Garber, I'll start with you. Reliant might have been the place where we would most expect to see telehealth being utilized even before the pandemic because you're in an outpatient setting compared to an acute care hospital. So how much did Reliant utilize telehealth before the pandemic, and how widely are you using it now?
So we had used telehealth for our most frail, elderly, homebound patients prior to the pandemic. We had used iPads, delivered them to their homes, and had done virtual visits with them. And the problem that we had is that a lot of these people did not have Wi-Fi networks. So we were putting a cellular card in the iPads, and the carrier, we only picked one carrier, but that wasn't necessarily the carrier that worked best at their house. So half of the sessions didn't work. And so we actually hadn't gone very far with our telehealth presence. After the pandemic started, within 2 days, we had 60 providers live. And then within a couple of weeks, we had 500 providers doing video visits. About 70% of our visits were via telehealth. And, and so we've performed over 100,000 video visits since the pandemic started. As the pandemic waned, we were down to about 15% video visits. And now we're starting to, get up to about 20% as we're starting to surge again. And today we're in the snowstorm, we're probably about 100% video visits.
I would think so. Yeah, there's, again, one positive out of this is people know how to meet with doctors or colleagues or others remotely. And as you're talking about some of the technical challenges, I think too of I'll ask you, Tamara, on this one with Community HealthLink. You have what can be an often a challenging patient population of people who are battling addiction disorder, behavioral health, homelessness, or other challenges. So how does your team make telehealth work with this population? Are there challenges around making sure people have the technology at home to have telehealth appointments if they might not have a laptop or a smartphone or reliable internet? How do you make that work?
Sure. So thank you for the question, Grant. We definitely have found that there are advantages and disadvantages to telehealth. At the beginning of the pandemic, we were able to get about 400 providers up and running on the provider side in about 2 weeks. So we expedited the effort on that side, but even 10 months into it now, we have about 50% of our outpatient population who struggle with using telehealth via smartphones or computers or laptops, just because they don't have the access or they don't have enough data, if you will, due to economic restraints. And, you know, in addition to that, just diagnostically, some individuals who might have, you know, disorders that would cause hallucinations of some sort, auditory or visual, you can sort of see the challenge that would present itself in having someone sort of talking to you through a box, and what that might, that experience might be for them. And even individuals who know how to work it at home, from home, but having many distractions and challenges within their home environment, if you will, if they're in a group home setting, or parents who have children, as you could probably hear the little one in my background, and how difficult it can be to just really navigate during this very challenging time. And so we definitely have found that there are advantages and disadvantages to it, but we have worked to create spaces on site where individuals can come and actually do telehealth, say from an office space. They may not be in the same space as their clinician or their therapist, but they can use it on site so that they have to worry about using all of the data or not knowing how to, you know, make certain functions work through Zoom or WebEx. I mean, it took me about 25 minutes just to get my audio to work this morning for this Zoom. So it's challenging, but there are some benefits there.
Right, definitely. And Dr. Viswanathan, I talked to you and a colleague at St. Vincent this summer for a story we had in WBJ's Quarterly Health magazine. You mentioned then that patients were generally becoming more comfortable using the technology even before the pandemic. So that switch was kind of already slowly taking place. So from your perspective, has it been relatively smooth in that sense, that enough patients have adapted well to being able to use the technology, or maybe they know of someone at home who can help them use it if they need it?
So yes, breaking it down into outpatient visits, I think a lot of people were starting to do because pretty much everybody has a smartphone or a cell phone that, you know, allows that kind of technology, and FaceTime and iPads. A lot of our clinics and outpatient settings, we have, you know, cancer center, we have pain clinic, where they were doing video calls with their oncologist or their primary care providers. And it was sort of already setting the stage for, I think, preparing us for the pandemic in a way where telehealth services could be provided seamlessly. I think there was an acceleration in the adoption of telehealth services since the pandemic because there was an urgency to get this moving. The second piece on the inpatient side, we actually found that the patients where telehealth was used the most was where patients could communicate with their family members when they were in the hospital. And we had to place restrictions in the number of visitors coming into the hospital because we wanted to decrease the traffic footprint inside the hospital at that time when we were in peak surge. So with visitor restrictions, we had to make sure that the patients weren't feeling the loss of not having their family members visit them. So we adopted to iPad and other technologies to sort of communicate patient to patient. And then we also adopted the same technology patient to specialist, where in the hospital, the specialist could actually do e-visits so that we were decreasing the footprint in and out of patient rooms, especially in the ICU and the COVID units. We just wanted to limit if possible. So I think technology has been a blessing in many ways with enhancing the communication that patients could have in the outpatient as well as in the inpatient setting.
Great. And we happened to report in that same story this summer that there were some other barriers to telehealth being used on a more widespread basis until the pandemic came and essentially forced its use. Among them was the way that health insurers reimbursed for such appointments. Today, insurers, along with Medicaid and Medicare, are paying the same rates for telehealth as they were for inpatient, or are for inpatient appointments. That wasn't the case before. So healthcare systems previously faced somewhat of a financial disincentive for switching to telehealth. Dr. Langer, I'll ask you through your view at Fallon, what the future holds for telehealth rates and how you see insurance providers handling this going forward.
Sure. We're doing a lot of thinking about this and specifically our strategy going forward post-pandemic. Let me just turn the clock back a little bit. So we actually had been covering telehealth services for over 3 years through a national vendor, and saw very little uptake. And then as Soumya was saying, with the pandemic, we suddenly saw a very quick adoption. And part of that was because we and many other payers started covering telehealth visits at 100% of the in-person rate. But I think there's some other important features that really led to the wide-scale adoption of telehealth. So for example, we expanded the modality. So we did not just limit it to video telehealth, but also covered telephonic telehealth. And I think this was particularly instrumental in really addressing health inequities. And we did see very good utilization among our vulnerable populations, such as our Medicaid population, and even some of our frailest seniors, such as those in our Navicare program, actually had utilization rates that were much higher than those of our commercial population. In addition to these steps that we took as payers, many of the regulatory agencies relaxed the HIPAA compliance standards. And I think that was really instrumental in making this modality much more accessible, particularly to some of our more vulnerable populations. Going forward, absolutely, I think telehealth is here to stay, including telephonic only, particularly given how we've seen the way that it has really been able to close that gap in terms of health disparities. So as I mentioned at the outset, we are doing a lot of thinking about how we're going to cover these services and also what types of services really are amenable to telehealth. We saw wide-scale adoption of telebehavioral health, and that has not diminished even when the first surge passed. So we're very optimistic that this is going to be a permanent tool in our armamentarium. And I would just like to see more published studies in the evidence-based literature really providing guidance on what sorts of indications and conditions are really appropriate and amenable to telehealth services. Thank you.
Sure, thanks. And just as a quick follow-up, what about co-pays? In some cases, I don't remember if it's with Fallon or others, that co-pays have been waived as a way to make it easier for people to see their doctors or carry through with these appointments if it's otherwise not so easy to do during the pandemic. How has that changed?
Yes, thanks for asking. So, even prior to the pandemic, we had waived co-pays on certain preventive services. But with the pandemic, we eliminated co-pays for COVID-related treatment delivered by telehealth. Again, we are assessing post-state of emergency. Of course, we're still in a state of emergency, but really assessing what our strategy should be long-term. We've been very encouraged by the use of telehealth and some of the gaps that it has addressed. And there are other things besides co-pays that we're doing. So for example, during the height of the first surge, we launched a program called Operation Stay Connected. And we did outreach calls to our most vulnerable populations. In fact, we made outreach to every single one of our Medicare members and our Navicare members, and continue to make outreach today to our Medicaid population to encourage them to use telehealth. Some of them are not aware necessarily of this as an option, and we've certainly seen, particularly in the case of seniors with chronic medical conditions and others who are high risk, concerns or hesitancy to go to their physician's office or even to go to the emergency room. And so we've been doing these outreach calls to really encourage them to consider using telehealth, again, where it's appropriate, so that they can get the care they need, particularly, again, for those who have chronic conditions and really do need to be seen and cannot forego their health care.
I'd like to jump in if I could. There's one other factor that Dr. Langer spoke about but didn't quite nail, which is you said that you'd offered a service, a national service to patients prior to the pandemic, and it didn't have a lot of uptake. And part of that is because we've surveyed our patients at Reliant, and we've discovered, obviously, trust is local. In other words, patients want to see their own care team. They don't want to see some physician who, God knows where they are. They want to make sure that they have the access to the full medical record, the provider does. And so, the fact that you're paying us as providers to provide this service is exactly what the patients want. They want their own doctor. They want, they want their own care team. They want someone who has access to the full record, and so that they get a better experience. And I think that's contributed to the uptake as well.
Yeah, Larry, I'm so glad you brought that up, because that is absolutely our philosophy. I would much rather, if a patient needs to be seen, that they get that care, whether it's in person or through telehealth, with their own primary care doctor, rather than some doctor in Texas or California, who doesn't know them from Adam. And as you said, doesn't have access to their electronic medical records, doesn't know their medical history. And one of the projects we're working on now is to try to put in place a streamlined process so that when members do outreach to us, we can direct them to their PCPs, in some cases using a warm transfer. So we're actually currently working on an initiative in collaboration with our nurse call line to try to channel patients directly back to their PCPs, rather than necessarily directing them to a national telehealth vendor. And, I think in some respects, we may always need some sort of vendor as a backup, but always our preference is for patients to get that care with their provider who knows them, to reduce fragmentation of care.
Agreed.
And speaking of patients being able to see either their primary care doctor or their specialist, many of us have probably been in the position at one point or another where you have to make an appointment, at least in pre-pandemic times, to go into the office, and there may be a long wait unless someone cancels, and you kind of hope that maybe someone's canceling so that you can be seen earlier. I've seen studies that have shown there's far fewer cancellations these days. That's one aspect of this. You don't have issues of people maybe being stuck in traffic after work, or having to pick up a child from sports practice, or any number of things. I'm curious if you folks have seen a big change in how many patients you've been able to see, and presumably you've been able to be more productive this way. I'll start back at the beginning with you, Dr. Garber, and then we'll move around to the other panelists. Do you find that your care providers are able to see a lot more patients these days, and they're having a lot fewer cancellations?
A loaded question. I mean, there are a few pieces to that. So I think in terms of cancellations, I think that we have fewer no-shows, in the sense that everybody's still sitting at home. So it's convenient for them. So we do, they're there. But we do balance that against the reality is that, we have about a 5% failure rate for the video technology. 19 out of 20 patients, we can get the video working, but there's 1 out of 20 where it doesn't work. And that's probably in the ballpark of our no-show rate. So that's been a wash. And then the other piece of it is, are we more productive? Well, most of us, in primary care, I'm an internist, and in a lot of our other specialties where much of the visit was always about talking, the visits take the same amount of time. And so that really hasn't changed. And we still have, I've got a medical assistant who rooms our patients through video, where, they'll call the patient first and get some of the history started before I come on and finish up the visit. So really, the one-on-one throughput for patient visits hasn't changed. What has changed is the use of group visits. So physical therapy is doing more group visits now than they did before. So they'll have these, they've got a big monitor, and they'll do a Zoom group visit where they'll do group exercises with a bunch of people. So they're actually allowed to, they're seeing an increase in their productivity. And then also behavioral health, where I should mention, we have 46 behavioral health providers. They've given up their offices. They are 100% virtual. And the area where they're able to see extra visits is, if we were in the office seeing a patient and we wanted to get an immediate consult with them, they physically had to get moved over to come to the office, to that exam room to see that patient. Now what we do is we'll actually connect them virtually via video directly to that exam room to talk to the patient, or if the patient's at home to have a virtual, tie them right into a virtual visit. And so they're able to be in more places at one time, and that increases their productivity. But the sessions themselves are the same length.
Right. Dr. Viswanathan, are you seeing that at St. Vincent too, that there's both an availability of seeing more patients, but sort of that potential of having a technology fail? Has it been a major difference in terms of how many patients are being seen in that way?
So yes, in the outpatient setting, I think Dr. Garber pointed it correctly that, you do have the visit time itself stays the same because of rooming and, just connecting with the patient and everything, and it's more the glitches in technology. Sometimes the video will not work or the audio doesn't work. So it takes a little extra time for the person behind on the patient side, if somebody can help them set up the technology. On the inpatient side, it's pretty interesting. We actually found that efficiency and throughput was actually improved because we have a telehub. So we have 2 large monitors. One of them is for the video call, and the other one actually is connected to our laptops and the computer desktop so that it pulls up the EMR of the patient. So what happens is, let's take behavioral health, for instance. If we have a few consults on the inpatient side and a few patients who are waiting in the emergency room requiring behavioral health consults, our psychiatrist is able to go in and just go one after the other and just be done with all the consults, because all these patient rooms do have iPad access. So they're not installed in the patient rooms, but we do have the interpreter iPads as well as iPads, which are on stands. They are mobile iPads. So the nurses will take them into the patient rooms and the psychiatrist is able to connect with the patient, get onto the EMR. So there's less time that's lost going from floor to floor, pulling up an EMR, their EMR on the computers locally, and then getting on, all those things take time, just going even from emergency room up to an inpatient floor or the ICU bed. This technology definitely has streamlined that process of efficiency with which the consults are done on the inpatient side. And just sitting in the telehub in one room in one session or 4-hour session, they are able to just scramble and get all the as many consults done as possible.
Right.
Thank you.
Sure, thanks. And Tamara, I'll ask you, kind of going back to what Dr. Garber said about how behavioral health is maybe as natural of a fit for telehealth as compared to other specialties. And that's a big part of what you folks do at Community Health Link. So how has it worked being able to provide behavioral health services? Do your practitioners say that it does lend itself pretty well? Are there some things that are maybe, you can certainly still tell someone's maybe body language, facial expression, the way they're saying things. Maybe there's some other things that are still a bit more difficult because you aren't face-to-face. So how have you found the behavioral health aspect to be working for telehealth?
Sure, I think it's both. So we found some providers who have found it to be very effective. We definitely have experienced what some of the other panelists have mentioned in terms of no-show rates decreasing for individuals, especially those who may be suffering from depression, and getting out and getting into the car and getting to the appointment is just a little more than they can do for that day, right? Now press the button and there's your therapist right there in your room. So we are seeing that as a benefit. We also serve a large child population, and one of the things that our providers are saying is difficult for the younger individuals who have been, say, on Zoom classroom discussions or doing work via Zoom with the teachers or other activities they're in. They're pretty zoomed out by the time they're done with school. And so some of our school-based clinicians and our, after-school programs, they're seeing it a little more difficult to engage children in the virtual world, and especially sort of our early intervention programs. If you can think about trying to get a 3-year-old to sit still for a 45-minute Zoom session, it's quite difficult. And so we're seeing some differences in the age and that population is sort of how they're responding to it. So our teachers our clinicians are getting pretty creative in ways in which we probably would have just never thought before. Some of our clinicians are dropping off arts and crafts kits at the clients' houses on their porches so that they can engage with them in art therapy during their sessions. And so they've just really become very creative. I greatly appreciate all of the work that my team has put into trying to make this new normal work, but it has presented its challenges.
Like that. And I'll ask you first for the follow-up question is how much a language barrier might pose, well, an additional barrier is whether it's Community Health Link or other providers, you may have to have a translator. How does that work with telehealth? Are you able to bring that other person in much the same way? And then for you other folks, if it applies to you, you can answer as well afterwards.
Sure. It's just sort of that one additional platform that you have to try to navigate. We use for video remote interpreting, which has sort of this telehealth component itself. And so trying to sort of sync all of those platforms together and hoping that the call doesn't drop because, then you have to start all over with a new interpreter. It can be a bit difficult, especially when you say you're 15 minutes or 20 minutes into a session that probably took you 25 minutes to get started. You can see how your hour can go pretty quickly. So that was some of the challenges we were experiencing at first. And some, we sort of still deal with even today in terms of bandwidth and just connection. But I would say that we have been successful in being able to get interpreters because they're experiencing the same thing I think that we're all experiencing in this new virtual world. So it continues to be a work in progress.
Yeah, we've had similar experience. We also use the video remote interpreter, but we use them almost exclusively for the American Sign Language, so that because they can see the signing. However, for all of our other languages, we actually just make a call, a multi-party call, so that the audio is through telephone where several people are connected, the interpreter, myself, and the patient, and the video is only myself and the patient. Because often, when I had an in-person interpreter, I would put them on the other side of a curtain when the patient is showing me something. So during the visit, if they're going to show me a rash from a sensitive part of their body, this way the interpreter doesn't see it, they're only on the phone, and that still works out just fine.
And Dr. Viswanathan, you mentioned before how St. Vincent uses telehealth, not just to see patients virtually, but also for patients to interact with family members who otherwise these days may not be able to visit them in person. Can you tell me how much of St. Vincent's use of telehealth is those types of visits, and how important has using those family visits virtually been a part of keeping people safe, allowing family members to stay at home, but also to interact with a loved one?
The COVID surge was a big eye-opener on that aspect, because when we had to start enforcing visitor restrictions to decrease the footprint within the hospital, to minimize the risk of people being exposed to somebody who's an asymptomatic COVID patient, or even the family members getting exposed when they come into the hospital, because the atrium and the cafeteria, you just never know who's going to be standing at the Dunkin' Donuts. So what happened was when patients were getting admitted, the inpatient med-surg floor or the COVID unit and the ICU, sometimes they would be there for several days, sometimes weeks, just because of their illness. And we started to see an increasing number of behavioral health challenges, especially with depression, loneliness. Even though the nurse and the doctors are there, they wanted to connect with their family members. And so we really emphasized a lot on, enforcing the visitor policy restrictions, but at the same time, making sure that the patients had access to iPad. Every ICU bed, the patients would be able to get the iPad anytime they wanted, connect with their loved ones, grandchildren, their spouses, anybody who they felt like they wanted to talk to. These are difficult times for patients. I mean, even without COVID, when a patient is hospitalized, we start to see a little bit of depression setting in and loneliness. So with the COVID on and no visitors allowed, it was very challenging. That was one area. The other area we found was on the positive side, when we have new babies are born. So babies don't stop coming, COVID or no COVID, babies come. So when babies were born and we had to put strict restrictions on just the spouse being allowed with the mom when the mom was presenting for delivery, in the past, we would have an entire family cohort that would accompany to see the newborn. And we had to place restrictions on that visitation as well. So this way they were allowed to see the baby, the newborn, and the family members could actually celebrate the birth of the new one and welcome the new one into their family. So we used telehealth quite a bit, both instances.
Yeah, it's great to be able to still have that. You can still see the new one, even if it is virtually. Not ideal, but still good to have that option. Just to kind of go back to a bit of the insurance aspect, and we're talking about from longer distances. One challenge that has remained is that providers are typically licensed to practice in just one state, which is not as much of an issue, of course, if the provider and the patient are in the same room. But it can become one during the pandemic, especially in an area like Central Mass, where you have patients who could easily live in Connecticut, Rhode Island, or New Hampshire. So Dr. Langer, I'll ask you, do you know if the state-by-state licensure aspect is still a challenge, or is that something that could be addressed in a regulatory way or some other aspect that allows people, especially maybe this time of year, if people are snowbirds and they're down in warmer climates, is there something that can be done about that?
Yes, so many states, including Massachusetts, do require the provider to be licensed in the state of the originating service, in other words, where the patient is located. And so, as you said, we did see a number of patients during that first surge try to escape to Maine and other areas out of state to get a little bit of respite from the pandemic. And there are several groups working on trying to change the policy, trying to get interstate licensing agreements in place. And I do think that is so critical, particularly if we want to continue to improve access to telehealth services. And I do get concerned in particular about areas where there are problems with lack of access, for example, behavioral health and certain types of specialists that are often difficult, particularly in rural areas, to access certain types of specialty care, such as dermatology and other areas. So putting in place these interstate licensing agreements would greatly help improve access for the residents of the Commonwealth, for sure.
Right. And speaking of people getting away for some respite during the pandemic, it makes me think of asking, and you do kind of hear these stories anecdotally or through some data of people in some small number, at least, fleeing larger cities for more rural areas because maybe they know that they can work remotely. But I wonder if any of you have found, if you're a provider who is right in Worcester and your patient is right in Worcester, maybe it's easy for them to normally see you in person. Maybe it's more of a challenge if they're a bit farther away in a more rural area. Do any of you find a difference in telehealth adoption between more urban or more rural areas? That might be a technological issue too, if you're dealing with people who are in an area that don't have maybe broadband or as great of an internet connection.
Yeah, from my experience, it's really not necessarily what community they live in, but more physically, what's their internet access in their home. I mean, I have it in my house. In fact, I think my connection may be a little flaky today as well. It really, depends on the service they have to their individual home. People who live out in rural areas, a lot of them have phenomenal broadband as well. So I haven't found a consistent pattern yet, at least in central Massachusetts.
And it's the same thing with me, Brent, that we have not found a big difference in terms of from a connectivity standpoint. I think if there's any changes in the way people want to connect with a provider in person versus via telehealth, it could be just sometimes it's the specialty oriented, like we find in the cancer center and oncology patients, they actually want to come in and see their provider. We have found that difference, but for the most part, not because of technology-based questions or problems.
And we've been thinking about this issue a lot as well, particularly because we do have a large Medicaid population in the Berkshires. And so it's difficult to tell right now if there are issues with access to the internet. I agree to a large extent with Larry. Some of this may be individually based. I think also the fact that we have offered coverage of telephonic only services has greatly eliminated some of those barriers. I would say also what I've seen is that much of this, as Samya was saying, was often specialty or even provider driven. I was very pleased to see some of our community health centers be among the first ones to pivot and move the majority of their patients to telehealth services. So we have seen, even in the same geographic area, some differences, again, largely driven by provider preference and provider willingness to adopt this technology.
And do you folks find that your care providers like using telehealth? Are they pretty satisfied with how it's worked out for them and to be able to still see patients? I can see the ease of use or the convenience of it. But I could also see, as Tamara was mentioned earlier, for people who have to drop off packages at people's homes, there's some aspect of the face-to-face interaction, depending on the specialty, maybe that's lost and that people are really still craving for. Maybe I'll start with you, Tamara. Maybe depending on specialties, how do you think that your providers, but also your patients are dealing with this? What has their feedback been on how they find telehealth to be working?
So I think it depends on the day. When we first started out, we were on a platform called Amwell, which was not as conducive to sort of the behavioral health delivery, if you will, for many of our providers. So a lot of them struggle with that. As we moved to the Zoom platform for most of our services, many people found that they and the clients found it to be user-friendly. It was something that they were familiar with. I would say that connection and being able to connect as individuals in person, that's really just a part of the work that we do. We're the tool in the room. And so for a number of our providers, they do feel like there's a sense of, or a lacking of being able to connect in person, and that there is something lost there, especially when you're dealing with situations that can be very touchy, if you will, if you're talking about very sensitive matters. And so we really have found that to be something that we are really trying to, again, just be creative around, especially if people are saying, talking about traumatic history or traumatic experiences they've recently gone through, or suicidal thoughts. If you just think about sort of the weight of the matters that you typically discuss with your therapist, and having to do that, say, in your home environment. We even have found that, individuals might not be as comfortable expressing exactly what's going on for them with their family members around or with friends around. And so people may not open up as much in a sort of virtual setting as they would if they were in an office setting, one-on-one with their therapist. So there is something lacking there for sure.
How about you, Dr. Garber at Reliant? What is the satisfaction rate been like on either the provider or the patient end? And does it vary much by specialty?
Yeah, I've been actually very proud of my colleagues. The fact that within a couple of weeks, everyone was doing video visits. we have 30 different specialties at Reliant Medical Group. And everyone was doing a video visit, and some more than others, more in the primary care and behavioral health departments, and nutrition. But there were some that were just complete shockers to me. For instance, in our OB obstetric department, they have 250 women who are doing, pregnant women who are doing remote patient care. So they're having a video visit with their obstetrician. And at home, we've set them up with a blood pressure cuff and a fetal Doppler, so that they're actually, listening to the baby's heartbeat, right through the video visit, and making sure everything's okay, so that they don't have to come in. And I just was, I never would have expected that. So our physicians and advanced practitioners have really risen to the occasion and done a phenomenal job. And the patients are liking it. I mean, this is all about convenience for the patients, really. I agree with Tamara that there are some situations where, the patients aren't comfortable, speaking freely at home. But then there are other, times when I'm having a much better experience with the patient because they're at their home. I'm in my home and they're in their home, and we're sort of, the playing field is leveled, and it becomes a much more personal connection. I've had a patient who, after we had this nice video visit, he said, thank you so much, Dr. Garber. I want to play a concert for you. And he goes onto his organ and starts playing this, this beautiful, concerto, and I've heard other experiences where, the behavioral health providers are getting tours of the house and or seeing the medicine cabinet and seeing what pills they've got. So there's a different, more intense level of connection that you actually can have when you're connecting one home to another. So it's been a real.
How about in an inpatient setting, Dr. Viswanathan at St. Vincent, again, to get to the aspect of whether people are able to avoid going into an acute care setting? Do you know if patients are thankful for that, or the practitioners are maybe as well?
Yes, absolutely. I mean, especially, if patients can connect and confirm that, their biggest fear is going into the hospital. Are they going to contract something? And if they can avoid going into a hospital, there's always this little bit of apprehension that comes with it. And definitely from the patient perspective, I think it's been an easier move. Although with the COVID, a few things have changed, because there's always this back end worry that they have. Do I have COVID? I need to get tested. So they do come in for those kind of things because they're worried any symptom could be related to COVID. So they do come into the emergency room. From the provider side, I think I have to say the adoption of technology from the provider side has been quite seamless. And maybe a little bit of, we have to applaud the fact that we rolled out electronic health records early on. So just even transitioning from paper medical charts, paper medical records, writing handwritten charts, to going on to electronic health records, sort of prepped all the physicians and the nurse practitioners and the APPs to adopt technology for documentation. And that led to, I think, the ease of adoption of telehealth services. I honestly feel like, their adoption rate has been seamless. We have not seen any significant barriers. For them to just adapt to, I want to say, certain specialties, maybe a little harder, like even physical therapy is able to show what kind of PT moves will help your back, or, you're coming in with knee pain, and how much ambulation do you need to do? Those things will require a little bit more, it required a little bit of structure. And each specialty had to sort of, figure out what is the process, what is the flow chart we need to use, what are the things we need to tell the patient when we are using a telehealth service. So adoption has been easy, but we have to create a structure around it.
Now, we had a story we published yesterday based on a JAMA internal medicine research paper that showed Massachusetts leads the country in telehealth adoption. It was close to half of our appointments are telehealth. In some states, it's as low as like 1 in 10. It sounds like a great thing. It does make me ask, is there a risk of ever going too far in one direction, where there are just some things that you would, this is post-pandemic, we're talking really, that you'd worry that, well, we still would like to have you come in for X so that we can run an ultrasound or an MRI, or just so that I can physically check the patient. Maybe we'll start with you, stick with you on this, Dr. Viswanathan. Is there any discussion of overuse or maybe particular aspects that once there is going to be an end to this pandemic, we think, that maybe people are talking about, all right, this is something where we really want to try to make sure people are seen in person if possible?
Absolutely. I think, there is that fine line. I'm sure Dr. Garber, can speak to this as well, because we do want to define at what point do we say, okay, it's okay for you who are complaining of abdominal pain, for instance, that I don't think this is something that's acute versus something that I think may require an evaluation to rule out appendicitis or something acute going on in your body. So there is that fine line where I think it's the physician judgment along with the patient's convenience and their comfort level to reach out again. So again, even with telehealth services, I think we have to streamline that process of follow through and follow up appropriately so that when the patient is in the outpatient setting and we say, okay, this is what we think is going on, but make sure that if your symptoms worsen, you are calling back and you are connecting and then documenting. So while telehealth is great, but there are many instances where we have to evaluate them. They need MRIs, they need CT scans, they need to be evaluated by a surgeon to see if they need a surgery. All those things will require the patient to have an in-person visit for sure. And that fine line has to define when does the patient come in and when do we think it's appropriate.
I absolutely agree. I just want to jump in there. It's, that's spot on. And so the reality is that a lot of these video visits, can focus on convenience and be a triage tool to determine, okay, you're at home and you can stay at home. I think you're going to be okay. Or you really need to be seen in person. And so instead of having to come into my office to say, oh, this is nothing, don't worry about it, now it was more convenient that it could have been done at home. And from an employer perspective, this is 20 years ago, Microsoft did a pilot, they called it Dr. Goodwell, and they had 150 employees with cameras at their cubicle, at their workstation, and they were able to do their video visits with a provider whenever they had a problem. They didn't have to go drive to an office and spend, an hour or two out of the office. They could have a quick video visit, and it was successful in the fact that these employees were able to quickly get their care and then get back to work. So the employers were very happy with that. They didn't have there was the issue about you're sitting in your cubicle surrounded by other people talking about sensitive rashes. So they didn't completely think this through. But it brings to a point that, this would be great for the employer and employee perspective if the employers would have set aside private rooms within the facility, within the workplace, where where employees can have these video visits, schedule these private rooms so that they don't have to go, lose so much productivity. Just like there are lactation rooms in most offices now, most buildings set up video visit rooms for your employees for that convenience. And I think everybody wins when you do that.
And speaking of post-pandemic, it's a nice thing to look forward to. Does anybody have any sort of predictions for how much telehealth will be here to stay? Dr. Garber, you were the main photo for that story we had for that quarterly health magazine, and our headline said telehealth is here to stay, because that was kind of what we found based on those that we talked to and some surveys. And to some degree, it certainly seems true that once people have made this adoption, either on the provider end or patient end, they'll be comfortable enough with it to continue to use it. But does anybody have any thoughts of, is it going to be maybe back to half of what it is these days, 3/4? Any thoughts of what it will be, or maybe even what it should be?
I'll jump in on that. So we know that patients, a third of the patients under age 40 prefer to have a virtual visit. In other words, they know They can do the technology, and they'd rather just stay at home or in the office and get this done without having to at their workplace and not come into my office if they don't have to. So I think that tells us that if you look across the population, we're probably going to have 20%. That's my guess. I'll put it out there. 20% is my guess of the in-person, face-to-face visits will be done virtually. But a lot of the care that we give is going to not just be at that time when I'm sitting in front of a camera or the telephone with my patient on the other end, but that we want to provide, and we are starting to provide care for all of the times in between those visits, which is the vast majority of the time in a patient's day. So we've got a bunch of patients now who we've connected their home scale, their home blood pressure cuff, a pulse oximeter. We've done it with activity monitors, Samsung watches, where we can actually load that information into electronic health record and alert us if there's significant changes that we need to reach out to the patient and talk to, so that we can keep track of them. And the fact is, okay, we're among friends, so I'll show you this. This is I think you can see that. This is called the bio button. And I'm piloting this. It's a new technology where it's keeping track of my activity, my heart rate, my respiratory rate, my body temperature. And there's some thinking that they may be able to detect COVID a day before I realize that I have it, based on changes in temperature and breathing. So there are all sorts of new technologies that will have phenomenal impact. So for instance, what they're going to be doing with these is, a workplace who wants to start coming back to work has everybody in the office wearing these. And so as soon as someone looks like they might have COVID, this doesn't have a GPS, but it does know who I've come in close contact with in the days preceding me getting infected. And we'll be able to say, okay, these are the 10. So a lot of amazing monitoring technologies are here and are coming. And it's going to be, so I think, in office is going to be less useful, less necessary.
Grant, I would also mention that I've been canvassing a lot of providers. This is a question of great interest to us. I would say in general, broadly speaking, many providers tell me that they would like to land at roughly 20 to 25% of their outpatient encounters remaining telehealth, and among behavioral health providers, even higher. And, this goes back to what Tamara was saying earlier, is that there is a huge convenience factor for patients in particular. So Tamara highlighted many of those individuals with childcare. We have many members who are really challenged by transportation issues, many who have mobility issues or otherwise homebound. And as Tamara highlighted, this has really been very helpful for many patients with behavioral health conditions, depression, ADHD, individuals with autism who have challenges with transitions or with sensory overload. So we do feel that there is a permanent role for telehealth, and are really trying to encourage providers to continue offering that post-pandemic.
How about at St. Vincent, Dr. Viswanathan? Any thoughts on how widely it'll continue to be used there?
I think the specialists are really, at least through this pandemic, they have really adopted to telehealth, using our telehub. And we thought once the surge, the wave 1 of COVID started to ease up a little bit late summer, we thought we could probably convert the telehub or keep just one hub open. We have 5 hubs. And we realized soon that, they wanted to keep it open for many reasons. Just like I said, from an efficiency perspective, from a throughput perspective, it was so easy for them to connect. And if they still had to evaluate the patient, there are many teams that go in and out of the patient rooms. There's a resident team that goes in and out. The PAs will evaluate the patients, and then the specialist also evaluates the patient. So they already have so many members going in and out that we wanted to continue that visitor restriction, which was one of the reasons we started it. But we have found adoption in many areas, and I'm only talking St. Vincent, but there are many other hospitals where you don't have certain specialty services. So we have found that neonatology, for example, or there is a tele-ICU that, there's a big hub in Midwest, which provides tele-ICU services, tele-radiology, tele-pharmacy. I mean, there is this whole telehealth specialty services that have become available. And these, from a global perspective or from a national perspective even, I think just in rural areas, remote areas, the tele-specialty services are going to be here to stay. And physician adoption has been very convenient for that.
And how about a community health link? Again, serving a more specialized population. Is there a thought that a lot of those ought to switch back to in-person, or if we're talking behavioral health, again, that's kind of the area that maybe makes the most sense to keep through telehealth? What do you think the post-pandemic there?
Sorry. So yes, I think that we currently actually are doing some in-person sessions and doing some in-person work for our populations because the need is there. We really are looking at it sort of a risk-based model. So those who are sort of high risk and need to come in, we're already seeing them in person or connecting with them in sort of local areas or public areas, if you will, for the purposes of social distancing. Those who are at the homeless shelter or those who need to be checked in on in terms of being at risk for homelessness. Those individuals we want to see because their situation, their state can change from day to day. But we do have those, like I said before, success stories and a number of people who find this to be convenient and are able to interact with their therapists and their providers via telehealth. And so where that's possible, we're going to continue to do that. It also has helped us to reduce our footprint in terms of actual physical space that we need. And being an organization that's always looking for an opportunity to maximize our resources, being able to have individuals work from home has allowed for us to really be able to utilize the space that we have at our disposal to the best of our abilities. And so we are, taking lemons and making lemonade out of this COVID-19 pandemic and finding that there are many, many advantages to doing telehealth and continuing to do so.
And we have just a few minutes left, so we'll end by focusing on the patient end. I'll ask this to each of you, kind of what you've heard in terms of how well if people were reluctant on either whether they could figure it out technologically, or there's always the people are reluctant to change, or they're worried about security. I wonder how much patients have been sort of won over on the benefits of telehealth and whether they'll see that it's something they want to continue to do. I'll start with you, Dr. Viswanathan. Do you hear much maybe from your providers that patients have felt like, all right, I was reluctant, but I can see why it's more beneficial to just maybe open up my laptop if I can do so and just speak to a provider from home?
I wouldn't say it's flicking the switch one way or the other, like in a snapshot. It's going to take some time for people to adopt to these technological advancements. But I certainly, we all have certainly seen an acceleration. The other piece that we have to touch upon is definitely the newer generations or the younger generations definitely quick in adopting technology. We all have seen it. Our own, my sons, they were on my chart touching base or connecting with their provider before I even knew how my chart was working. I mean, they were already communicating, exchanging information about, when appointment, do I really need an appointment? And before I could tell him, and he is 24, and he was like, yeah, I've already connected with my PCP. I'm all set. You don't need to worry about my health. I'm taking care of myself. I'm like, wow, these kids are really grown up. So it's interesting how generationally, I think, from the general population, they will definitely be more in tune with adopting to technology. And we saw that with globalization, that people are really in tune with what's happening globally. So they want to really get the best advantage of what is out there from a technology perspective. I think one of the shortcomings will be to make sure that the broadband, the Wi-Fi, and from the infrastructure perspective to provide that heavy lift on telehealth will continue to be enhanced.
And the payer reimbursement.
Yes, of course, for us. Yes, totally agree.
And it kind of reminds me, to get back to the security aspect of maybe even people shopping online. Yet you think of how widely that's in use now. It's everywhere. Is it the one aspect of the economy that's done well is e-commerce. There was a time where people were much more apprehensive about paying for something by credit card online. Now it seems like people are feel more secure about that. Has anyone felt that concern has maybe been allayed, that there's not that concern of, well, I'm talking to my provider online and I'm talking about a very personal situation. Is this secure? Is that still something anybody is hearing, or has that also been?
We make a point. I mean, we make a point of telling our patients to, find a secure location that's quiet and private, so that they can show me parts of their body that they're concerned about, and we show that we're coming from a professional location that is private and secure, so that that really hasn't been an issue. And we know that the platforms that we're all using are HIPAA secure as well. So that hasn't been a problem. I did want to touch base on one thing you had asked before, though, about what the patients feel about this. Most of my patients are older, because I'm older too, and it's interesting how thankful they are that we were able to do this. And some of that, I don't know whether some of that thankfulness is just because it was convenient for them and they didn't have to leave the house. Some of that, I think, may be related to the pandemic, that they're just thankful to be able to speak to another human being from their home. That I think everybody's craving that connection. And so it's nice to be able to talk to someone.
Yeah, and at Fallon, we've seen very good reception among our membership in the adoption of telehealth. As I mentioned before, I was just blown away by the data, particularly among not just our Medicaid population, but our seniors in really adopting this technology. I have not heard of any concerns about privacy issues. And I mentioned earlier that part of the, I think the cause for the wide-scale adoption is the fact that the HIPAA compliance standards were relaxed. I do worry post-pandemic, the regulatory authorities start tightening up those HIPAA requirements again. Can we make sure that the technology continues to remain affordable and accessible both to providers and to patients? But from what I have heard, patients love this. We talked earlier about the convenience issue. If you're a parent who's working, whether you're working from home or working at your workplace, it's great to be able to have a 20 or 30-minute telehealth visit instead of having to kill a whole morning driving a kid to a pediatrician and waiting in the waiting room and then driving back home. So we have seen very good favorable reception on the part of our membership.
Great. Well, thanks so much again to our panelists. That'll wrap up our session. Thank you to Dr. Garber, Dr. Langer, Tamara, Dr. Viswanathan for being part of this webcast. We appreciate it. Special thanks again to our sponsors, Fallon Health and Webster 5. As I mentioned earlier, everyone who listened in will receive a link to today's webcast recording. Thank you again so much for joining us. Everybody have a great day and be safe.